When you say, yeah, I've been through it, then your credit level changes quite a bit.
From med student to heart patient to heart surgeon, this health system thoracic surgeon shares his very personal journey with the same heart condition he now treats.
From the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning and thanks for joining us. I'm Alexis Delcid. When you have a serious medical problem, it can feel scary and lonely. And finding someone who's been there isn't always easy. In fact, finding a doctor who's been through the exact same thing is rare. That's part of what makes Dr. Todd Crawford remarkable. You've seen him here as a guest on our shows before. He's an incredibly talented surgeon, but for this episode, for our purposes today, he's the patient. And his experience is what enables him to connect so deeply with his patients. Exactly 3 years ago today, he underwent the exact same life-saving surgery he now performs.
Oh, she loves this.
She loves this, yeah.
With his wife and kids in their cozy living room.
Go, Emmylou.
Good job, Emma.
Their son proudly showing off his collection of cars, airplanes, and trucks.
It's a Jeep.
Their baby girl just learning to crawl.
Oh, she's doing yoga, look.
Dr. Todd Crawford is content.
You want to get in the mix?
Years before this beautiful life, when he was just 19, he went to the doctor for chest pains. That doctor referred him to the University of Kansas Health System for more testing.
And they identified an abnormal aortic valve and an aortic root dilation, as well as ascending aortic dilation.
That's a lot of scary words, but his wife Tori, who happens to be a physician's assistant, has gotten used to translating.
A normal aortic valve has 3 leaflets, his only has 2. Basically, the blood's not flowing through the valve as it should, and as a result of that, his aorta, which is where the blood leaves out of the heart, has gotten bigger, and it's not good when it stretches.
For an aorta, that can be a catastrophic problem if you have an aortic dissection or your aorta ruptures.
But surgery also had its risks, and this was major surgery. While most open heart surgeries involve stopping the heart for some period of time, this particular surgery required all the blood flow to Dr. Crawford's brain be shut off for a full 18 minutes.
It's very safe and very controlled, but when you're the patient, someone tells you that they got to cool you down and shut off blood to your brain, it's a little intimidating.
So the plan was to wait and monitor his heart until absolutely necessary, and that worked for 14 years, until it was finally time.
The day of surgery was probably the hardest day of my entire life. Not physically, but mentally and emotionally.
He was about to undergo a surgery that terrified him on a very human level. And at the same time, something was triggered inside him. It sparked a career path that would ultimately lead him to specialize in this very surgery, where he now performs it on patients on a regular basis right here at the University of Kansas Health System.
There was really no other career path at that point that would have made me happy.
We are so pleased to have Dr. Todd Crawford and his wife Tori joining us in studio today. Thank you both for being here. We also have thoracic surgeon Dr. Greg Muehlbach. Now, Dr. Muehlbach, you don't treat Dr. Crawford. However, you play a very important role in this because you're the reason we have the honor of saying Dr. Crawford is one of our surgeons here. So we're going to get that in just a moment, how you brought him to his dream job. Thank you for being here as well. Dr. Crawford, I want to start with you. It's been 3 years to the day. What's it like watching your story now?
It's hard to believe it's been 3 years. I feel like Tori and I have been on quite a journey since then. So, but it's humbling, and you know, you feel so grateful to be where you are and doing what you love and living a relatively normal life.
I can see your eyes and Tori's eyes kind of moisten during the story. Does it make your heart race to still go back to that point?
I think that it's nice that we're doing this because I almost like forgot that it's been exactly 3 years, and I feel like a lot of times we almost block out some of those feelings that make us human, but it was a scary time, and now kind of we just moved past it.
Tori, we have to say you're also glowing, and that's because you have some good news to share with us. There's about to be you're about to be outnumbered at home, right?
Yeah. So we've been, So now we're about to have our third baby in April.
You're due so you're 7 months along. How are you feeling physically?
I feel good. I feel pretty tired with the other two, obviously, because I haven't, you don't get to rest. But yeah, I feel good.
Well, congratulations.
Thank you.
On the new baby headed your way. That's so sweet. Dr. Crawford, I want to dive right into this surgery because, first of all, when I hear stop patient's heart and stop blood flow to brain for 18 minutes, how is it possible to do that without causing brain damage? You do it all the time.
Yeah, I tell patients all the time it's an interesting day job, but it's one that we absolutely love and cherish. So the protection is afforded by cooling. So with hypothermia, we can reduce the metabolic demand of the brain and prevent injury associated with removing oxygen and nutrient delivery to the brain for a period of time.
So when you're talking to the patients before you perform the surgery, do you ease into that part? We're going to stop your heart and stop blood flow to your brain. Do you just say, hey, here's the deal. I've had it done on me before. How do you explain that?
I try to be nonchalant about it because, the truth is it's fairly routine for us. It's part of what we do. It's a technique that's been practiced for decades, and it works. It's reproducible, and patients recover with no neurologic sequelae. So.
Neurologic what?
Like neurologic complications from having their blood flow shut off for a short period of time. But I don't try to overemphasize that part because anyone that is told we have to cool you down, pack your head with ice, and then we're going to shut blood flow off to your brain for a period of time, it's hard to hear those words.
I can imagine, and
Yes.
you had to hear those words.
Yes, absolutely.
Which is probably very helpful to the patient you're explaining it to.
Yeah, I think certainly a shared experience is one of the easiest ways to connect with an individual, especially a patient. And I don't always share that information, but there are times when patients are, you can tell, uncomfortable with the situation or the proposed intervention, and being able to say, I've walked in your shoes and I know what it looks like afterwards, and then for them to see your recovery, the fact that you're back to a functional life is really important. It's more than just surviving an operation, which is the first crisis you face as a patient. Am I going to survive this? Then the next question is, especially for young patients, can I get back to the life I was living before?
Right. We have some pictures from Dr. Crawford's surgery. I'd love it if you could walk us through them. We put them in the monitor so that you and Dr. Muehlbach can explain what we're looking at here. This is a view you see every day. The inside of someone. This is your heart we're looking at? What are we looking at?
So this is looking down at the aortic valve from an opened aorta, and this is a deconstructed aortic root. So the aortic root is the first part of the aorta where the aortic valve exists, and specifically where the coronary arteries or the arteries to the heart muscle come off. And you can see them at the top right and bottom left corners where they've been cut away from the aortic root, now just exposing the valve. So you can tell that the valve is not normal.
So what's not normal about this valve? Because I couldn't tell by looking at it that that's not a normal valve.
So a normal aortic valve should have 3 leaflets.
Point for you?
Sure. You can, you're mic'd, but you can.
Chair, I hope I don't fall.
Yep. Let's see here.
Okay.
Dr. Muehlbach's going rogue. All right, yes, help us.
So this would be 2 leaflets, as opposed to, that would be 1, 2, and then 3. His is 1, 2.
Okay, so that's what Tori was talking about in the story ahead of this, is that you were just born with 2. And we have another image I want to put up that's helpful. What's that we're looking at?
So this is the completed valve-sparing root replacement. So this is a reimplantation procedure where the aneurysmal or abnormal aortic root has been cut away, and the aortic valve is resuspended.
So there's his valve.
Is resuspended within this tightly woven polyester graft.
So what's that? That's made out of the polyester?
Yeah, so that's the
looking
graft
at?
material, and then you can see at the very top left of the screen where one of the coronary arteries has been reimplanted. You see the blue Prolene suture at the top there. That's where one of the coronary arteries has been reimplanted. And then at the bottom, you cannot see it as well. That's where the other coronary artery has been reimplanted.
And then we have a third image to pull up. Let's go to that one. So is that the completed?
That's the completed result. So when we talk about cooling patients down and then shutting off all blood flow, you can see at the very top of the screen, that's where my aortic arch has been reconstructed with graft.
So the head is up here.
Is it weird to see these pictures and know that's you, that's inside you?
It is. It's just such a normal picture for me that you kind of get accustomed to it. But when it is your own heart, it's a little different.
How do you cool the patient down? You mentioned packing them with ice. And you're welcome to sit down if you want, Dr. Muehlbach, or we can make you stand the whole time.
Yes.
Work those quads.
That's right.
There you go. Oh. Thank you for doing that.
Challenge.
No, it really helps. It really helped explain it. Cooling down the body. So walk us through that process.
Sure. I think we may have one more picture too
okay.
that may do some justice.
Okay, and that's all the tubes and wires that contributed to the cooling?
So it's more simple than it seems. You know, we place patients on cardiopulmonary bypass to do open heart surgery every day. And through the cardiopulmonary bypass, we can systemically cool them based on the temperature inflow of the blood into the body. So at the top of the screen, that big tube coming out is actually in the aorta. And then at the bottom of the screen, the darker blood coming out from the other tube is in the right atrium.
Okay.
And so that cannula drains blood, and there's another smaller cannula at the top with dark blood too that's actually in the superior vena cava. But that drains blood back to a pump, which we then use a temperature regulator to control the temperature of blood flowing back into the body.
So you are cooling the whole body just by these pumps and cannulas coming in and out of the heart?
Exactly.
Is any ice involved in any of it?
So it depends on the institution. At our institution, we do pack the head with ice to improve cerebral protection, but that's the only ice involved.
That's wild. Is it rare to have one of your surgeons working with you that's gone through the same procedure they perform all the time?
For this one, yes, but this is the bicuspid valves are the most common congenital abnormality that we see.
Right.
So although it's rare, we'll see 4 or 5 in a given day in clinic, each of us, and because of, just like him, the things that occur when the valve's abnormal. So although it's rare, it's 2% of the population. It's still something we see on a regular basis.
How long have you known Dr. Crawford?
I think I knew him when he was a medical student.
Okay, tell me about that, because he went through medical school here?
Right.
Okay.
Right. No, I did first get introduced to him as a medical student, but then also I think I remember somebody showing me his scans saying, what do you think, do we need to do anything? Because when he was initially seen, although it was abnormal, he didn't meet any of the criteria to have surgery at that time.
Right.
So did not have surgery. But no, as he went through medical school here, and then there were maybe even some predated affiliations that he had with some of my children, I hate to even admit.
Wait, time out. Predated affiliations. He was friends with your kids?
They were fraternity. They went in school together, but they were in the same fraternity.
I love that.
Yes.
Just sidebar, isn't it weird now? I'm about to turn 50. It's weird to be working with people that are half my age.
When I turn 50, that'll be weird. I am looking forward to that day. But, and Todd was a superstar medical student, and we knew when he left that, we had always hoped that we would get him back here, so he tantalized us and came back and interviewed for fellowship training here, but turned us down and went to a different program, which is probably one of the top programs in the country. And then, thankfully, when he finished there, he actually really did come back to interview for a job with us, which we were lucky to get him. So all
the drama happened when Tori and Tori, you and your husband, Todd. Dr. Crawford has asked for us to call him Todd. It's awkward to call a doctor by his first name, so I'm going to kind of volley between the two. You met when you were also working at the same hospital on the East Coast?
Yes. Yes, we met in room 48 in the medical ICU at Johns Hopkins Hospital, yeah.
Were you working on the same patient?
We were working on the same patient, yes. We remember
So this was like
him
one
very
of
well.
those Chicago Hope or the ER dramas?
I wish it was like that.
Yeah.
I wish it was like that. But yeah, we met there, and then we had some mutual friends that, you know, some of our best friends who are still our best friends today, you know, kind of brought us together a little bit more, I would say.
So through all this monitoring, the 14 years of monitoring, you meet Tori, fall in love, get married, have a baby. Your son was 10 months old when you underwent that surgery. Tori, for you as a physician's assistant, you have an extensive medical background. Did you go into medicine mode, trying to figure out how am I going to help my husband get through this medically, or were you in worried spouse mode?
I think I started off in physician assistant mode. I was like, you know, you're being a bad patient. You're kind of ordering your own CT scans, and we're just kind of doing this. Like, you need to see a surgeon. And so when we were at Penn, then we ended up going to see, you know, the people that they were training under, and one of our good friends, Josh Grimm. And so it was kind of like, I kind of pushed him to like make this appointment, and then when they were like, okay, let's get you scheduled, I was kind of like, whoa, wait, we're really doing this now? And it kind of felt like a little bit scary. I was like, oh no, maybe it's too soon, or maybe like, I just didn't think the time would ever like really come. But then when they were like, it is time, then I went into worried spouse mode.
I imagine it's hard to not be in that mode all the time. Dr. Crawford, Tori said something. You were ordering your own CT scans?
Well, I think that's a little extreme. I would say I was not the best patient, but you know, I was in the middle of training, and so it was more difficult to make time.
So you were doing what you tell your patients not to do?
Exactly.
You were putting off going to the doctor?
Exactly. I was compliant with my medications, but in terms of follow-up, you know, it was a little more challenging.
Right. So good thing Tori was kind of eagle-eyeing you.
Yes.
Watching that.
She rapidly shifted from PA mode to worried spouse mode.
Okay. It's effective. That's more effective sometimes, I think. Your condition, Dr. Crawford, what you have is congenital. Are there other people in your family who've been diagnosed with this?
So that's an excellent question. So we know bicuspid aortic valves can run within families. There's not a clear or complete penetrance, but it does tend to be passed more often to male offspring. You know, we unfortunately learned that my son has a bicuspid aortic valve as well when he was in the hospital for an unrelated issue. But you know, it is important for families to know, and it's actually indicated for all family members, first generation family members, to get tested. And that can be done with just an echocardiogram on an outpatient basis.
Do you know if your dad had it?
We don't. I hope he's watching this.
Does he not want to get tested?
Echo.
What happens when someone's diagnosed with this? Is there a medication, Dr. Muehlbach, you can take to keep it under control?
Well,
so
the bicuspid valves have kind of varying times of where they present and cause problems. So we'll see infants that need to be addressed. You see late teens, early 20s that need surgery. Then we'll see kind of the usual age group we see is the 40 to 60s. And occasionally we'll see people that go even beyond that into their 70s and 80s. And in some occasions we'll see 80-year-olds getting bypass surgery. We do an echo and they've got a bicuspid valve that looks normal, so or is functioning normally, I should say. It doesn't look normal, but so it's hard to say you have a bicuspid valve and then you'll need surgery like Todd did at his age versus one of the other categories. So medication-wise doesn't change the outcome of the valve. The valve kind of does what it does. Yep. But you do have to treat the other underlying factors. So if you have an aneurysm, which bicuspid valves are very commonly associated with aortic aneurysms, you need to treat your blood pressure. So there are other things to treat, but unfortunately there isn't a medication that's going to change the outcome of your aortic valve, at least none that we know of.
When you're doing the surgery, can you explain in lay terms, why do you have to stop blood flow to the brain, Dr. Muehlbach?
So the main reason isn't the bicuspid valve, it's the aneurysm. So
Okay.
not all bicuspid valves have aneurysms, and not all people that have aneurysms have bicuspid valves, so we can go back and forth on that. But the ones that do have aneurysms, if the aneurysm extends into what we call the aortic arch, so the aorta comes up, makes the turn and goes downstream, then we have to replace that abnormal aorta, which extends into the aortic arch. We typically put a clamp on the aorta, stop the blood flow to the heart. We do our work and take the clamp off, and in the meantime we're giving blood flow through that big cannula, that big tube you saw, to the rest of the body. But in these operations, we have to actually work on that area of the aorta. That's part of the aorta that's abnormal. So you're excising that part of the aorta. So in doing so, you need to remove the clamp, but you obviously can't work if the blood's flowing in your face. So we have to turn the bypass machine off for that period of time to reconstruct the aorta and the aortic arch. And then once that's reconstructed, then we can move on. So his surgery didn't take 18 minutes. It's sewing the two ends of the bypass, the graft conduit to his aorta, and then reestablishing the blood flow to the brain. That takes 18 minutes. The operation takes 6 hours, 8 hours.
Wow. And so for 6 to 8 hours, this major surgery is happening for 18 minutes, blood flow to the brain. Now, is the 18 minutes a hard cutoff? Like, you can't stop it for longer than 18 minutes, or 18 minutes is just how long it takes to do what you've got to do?
18 is individual to what it took.
What happened with, okay.
So there is some kind of guidelines to, or not guidelines, but understanding that you really don't want to be doing this for, really 45 minutes, an hour. But there are times that we don't have the luxury of making that decision. If you're not done, or there's a more complicated reconstruction, it may take longer. And so you have to get the work done. And there's other techniques that we use today that are allowing us to have extended times of circulatory arrest, that we call it. So we continue to perfuse the brain in different ways. But you also have to remember, it's not just the brain that's not getting blood flow, it's the liver, it's the kidneys, it's the intestine. And so there are other complications that occur. So this circulatory arrest mode is a very challenging part of the operation in many respects.
It's fascinating. We have so many questions coming in from our community, so I want to get to our community questions. You can send them to us in real time on YouTube, Facebook, the X platform, or you can send them to us at our email, the All Things Heart email. It's all right there, the ways to connect with us in real time on your screen. And I want to get to some of the questions that viewers have emailed us. Betsy wants to know, Dr. Crawford, have you had to make day-to-day changes or limit any activities?
That's a great question. Before I underwent repair and was living with aortic dilation or aortic aneurysm, I had significantly curbed my lifting activities. Not that I was ever a bodybuilder by any means, as Tori would let you know. But we do restrict what we recommend patients to lift. When you perform isometric exercise or heavy weightlifting, you can raise your blood pressure acutely to 200 or even 300 millimeters of mercury, which puts you at risk for an aortic complication. So that was the main limitation in activity, but aerobic exercise, I was still pretty active and in good shape.
Marie wants to know if you've had to avoid any foods, or have you changed your diet since all this?
That's a good question as well. In patients that undergo prosthetic aortic valve replacement with a tissue valve, such as a bovine pericardial valve or a pig valve, we do oftentimes limit fortified calcium in their diet. I still have my own valve, so I haven't made any particular dietary changes.
You limit calcium if it comes from a pig or a cow?
Because it can lead to we think it can lead to earlier deterioration of those valves due to calcium buildup.
Jennifer asks, what was it like to go back to work as a surgeon when you were so recently the patient getting operated on?
That was incredibly challenging. I was not only a surgeon, but a surgeon in training. So you know, at that time, you're learning how to operate, you're learning how to do highly technical operations, care for very complex patients, and you're also trying to recover. I had a lot of support from the institution I was training at, the University of Pennsylvania, and had an appropriate amount of time off and then was ready to hit the ground running. That being said, I didn't really want to hit the ground running. I had scheduled an Uber for my first day back, which didn't quite show up, and had to walk a mile to the hospital.
Oh my gosh.
I don't even know what my heart rate was by the time I got there.
Did Tori know about that, or were you just like, bye, I'm going to the Uber?
Yeah, not until after you did. Was it a transplant? I can't remember what case you were doing that day, but it wasn't until after that I found out that this had happened. Yeah.
Oh my gosh. I have a question for Tori that came in from Sherry. Sherry wants to know, with a new baby, husband after open heart surgery, and working full time, how did you manage?
Family. We had lots of support from both of our families, and we had really good friends. You know, one of our best friends is one of the surgeons that performed the surgery on Todd. So, you know, his wife brought over lunch to me, my aunt, your mom, your dad, my parents, my sister. There were so many people that helped us. You know, my aunt kind of babysat Todd one day when I had to go to work, and like
how'd that go?
Things like that.
She was an excellent caretaker. My sister flew out for a week when Tori went back to work, and so we had a really, I mean, like Tori said, it was a great team.
Tim wants to know how often you performed the surgery that was done on you.
So the valve-sparing aortic root replacement is rare. We select patients carefully, especially younger patients, because we know that when you have to replace an aortic valve in someone in their 30s or 40s, it can change their lifespan. You know, that you either endure the complications associated with having to be on lifelong anticoagulation, or you endure the challenges of a bioprosthetic valve that is not infinite. You know, it has a limited durability. So, but the aortic aneurysm work we're doing every week here.
Every week.
And we have an amazing team in the operating room that involves nurses, perfusionists. Our post-operative ICU care is spot on for those patients.
Wow, it must be so reassuring. I can only imagine being a patient of yours and then being nervous and you being able to say, well, actually, do you ever show them your scar and say, actually, I had it done?
Not intentionally. Sometimes it sticks out of the scrubs.
But it's so reassuring because you're a top doctor doing the surgery and you're fine. So they know they can feel safe going into it. I think it's really something to learn this story and hear you talk. I want to bring everyone back for some final thoughts on this program. And Dr. Crawford, I want to ask you, do you think this has shaped how you practice medicine?
Oh, incredibly. You know, it's a unique connection you can make with patients, not just before surgery, but when they're in that early phase of recovery, you know, when they're in pain, when emotionally or mentally they can be struggling with being a patient and trying to get back to what was their normal way of life. And I think just that reassurance that you will, you know, seeing someone that has gone back to their day-to-day life is really powerful for patients. And so that's definitely been a unique bond that I've shared.
Tori, for you as your healthcare provider, a spouse, a mom, for people watching this that might go through something similarly scary, what would you want to tell them? And also, what would present Tori want to tell past Tori?
To calm down. It's going to be okay. I just, you know, it was a unique situation because when Todd was getting his surgery, it was COVID, so I wasn't allowed to have anyone with me at the hospital. We were very kind of isolated. I couldn't leave and come back, so we were both there for 5 days straight together. And so I think just trying to remain calm and be supportive, and Todd always says I could have even been more supportive. He always says I was sleeping in the middle of the night when the nurse would come. But yeah, I think just to tell yourself to remain calm and that it's going to be okay, because you get so worked up and so stressed about all the things that could go wrong. And I think maybe being in medicine sometimes makes you think of all the worst case scenarios, but these people, you know, you guys are so well trained. Everyone is at the top of their game, and they're doing the very best they can for your loved one. So you have to let the doctors do what they need to do, and you need to be a supportive.
I imagine it's a double-edged sword.
Yeah.
You almost know too much because you know everything that's going to happen, but yet you can reassure you could be reassured it's going to be fine.
I was watching for that clamp time, the 18
Oh, you
minutes.
were? So you
yes.
were.
I was wondering how long that was going to be.
Were you watching the surgery?
No, I was not actually watching. I was just getting updates.
I thought maybe they would let you if you were a hospital employee, or
I wouldn't have been able to handle that. Yeah.
Wow. Dr. Muehlbach, is it important to you as a doctor to have a team with you that makes that personal connection with their patients?
Oh, I think you have to if you're trying to get them to trust you, and we don't expect that people understand the intricacies of the operation that we're doing, and sometimes we actually are maybe trying to reinforce to them how risky and what we really are doing. But on the other hand, you want to have that relationship with them that they understand that this is what we do every day. So this is our routine. This is what we do every day. And so we're comfortable doing this, and we know that we can do a good job, and we have a good team to take care of them. So getting them to understand that and then have that trust in you and the trust in the rest of the team is very important when you're taking on something like this.
And I've interviewed your patients before. One of your former patients, Irma, who was an 80-year-old woman who said she was so terrified, and then you came in and said, "Don't worry, I got it. I do this all the time." And that's what she needed to hear. She didn't need anything but that, and that provided her such comfort. So that's pretty special to hear. We know you're an incredible surgeon. We know Dr. Crawford's backstory, and now we know a little bit about him and Tori and their beautiful kids. But Dr. Muehlbach, you're one of our most hard to snag doctors because you're very busy and you're very mysterious. However, we asked for some personal family pictures, and we were so happy to see what you're like in real life, outside the hospital walls.
Now for a secret look into the guardians of healthcare at the University of Kansas Health System, let's go behind the mask.
Okay, Dr. Muehlbach, you have some beautiful family members. Tell me who we're looking at here.
So this is the next Dr. Muehlbach. So
seriously? There's another one in the pipeline?
Well, wait a minute.
Okay.
There's two in there right now.
Okay, tell me everything.
Well, my wife is a doctor too.
What kind of doctor is she?
Anesthesia.
Is she here at the health system?
No.
So when you go home...
She's retired.
We're going to get to your son in a minute. When you go home, do you talk medicine, or are you like, enough of the medicine, let's talk about potatoes?
Yeah, well, maybe a little bit. She understands. I think like Tori, she has enough of an understanding to know, that we have the conversations, but on the other hand, we don't get too hung up in it.
So there's Dr. Muehlbach, and then who's in the center?
And then that's my fourth child, William, who's a first-year medical student. So the next one to come.
And what's he going to, what kind of medicine?
He doesn't know yet. He's still deciding, but he's a first-year medical student here at KU. So
wow.
It's been great. Very exciting for me to see him every day. And
you must be so proud.
Yes.
Do you guys eat lunch together? Does he come up and hang out with you?
He doesn't really hang out with me yet, but he's got his own gang.
I love that.
Yes.
And then we have another group picture that you shared with us. This is a really nice little group. Is this another future generations of doctors?
Who knows? Who knows? Those are my grandchildren. Maverick
adorable.
On the right, and Marigold in the middle, and then Mila on the left. So
those are some great names.
Yes, all
Maverick,
M's.
Marigold, and Mila.
Yes.
Muehlbach.
Correct.
Double M's.
Correct.
Do you call them like the M&Ms?
That's
or
right.
Like those?
Exactly.
I love it. They're so cute. And then what are we looking at here?
This is what happens next for the Crawfords too. So that is my daughter in the middle, Audrey, who got married this past summer, and that's the whole gang put together. So we have 5 children. And then 3 grandchildren.
I love it.
Yeah.
And so you, your wife, and your son are doctors. Any other budding doctors that are talking about it right now? Or?
Well, I would be remiss. My third daughter, Molly, is going to be a doctor, but she's going to be a PhD doctor.
Okay, that's still a doctor.
Yes. Absolutely. Absolutely.
Wow. Thank you for sharing those pictures.
Yes.
I love getting a peek at the doctors' personal lives, and I know that our audience really likes having that connection as well. And I also want to talk about how February is Heart Month, American Heart Month, and there is a simple test you can schedule to learn about your heart health. It's called a cardio score. A cardio score measures the amount of hard plaque in your coronary arteries, and if those get blocked, you can have a heart attack. Coronary artery disease is a leading cause of death for both men and women in the U.S. The test itself is very easy. That's actually our boss getting a cardio score. We sent her through the machine. Scan the QR code on the bottom right of your screen. You can book an appointment. It's that simple. And for the record, Jill, our boss, scored a 0. It's the only test you want to score a 0 on.
That's right.
That's what we say, especially if you're thinking of all the ACTs and SATs everyone's prepping for.
Yes.
Do you want a 0 on those? Cardio score, yes. So thank you for being with us today, and a huge thank you to Dr. Muehlbach for your time, Dr. Crawford and Tori for sharing your personal journey with us. You are all amazing. Coming up next week on All Things Heart. Misdiagnosed for years, stuck on oxygen with no answers until she came here to the University of Kansas Health System. Meet the patient and the doctor that this patient says gave her life back. That's next Thursday at 8 a.m.